Hi, everyone who's joined. Welcome. We'll just be beginning in another 1 minute. We're just letting some more people enter the room. Great. So good morning and good evening to those joining in India. My name is Patty, and I am a researcher at Sangath with our adolescent mental health programs. For those of you not familiar with Sangath, we are a research nonprofit in India that works on developing and scaling effective community-based mental health interventions and services. One of our key areas of work is adolescent mental health. On behalf of Sangath, I'd like to welcome all of you joined today to our monthly research webinar series. These are held once a month, and the aim is to really present the latest research from academics, from practitioners, and people with lived experience, and provide a platform for our audience to learn, to engage with new ideas, and ask questions about your own research or your work. Today, we're really honored to have Dr. Daniel Michelson from the University of Sussex. He will be talking about designing and evaluating adolescent mental health interventions in low-resource contexts. Daniel is a senior lecturer at the University of Sussex, where he leads a portfolio of applied youth mental health research in the UK as well as internationally. He completed training in clinical psychology at the Institute of Psychiatry in London, and he's also worked at NIMHANS in Bangalore in India. Since 2016, he has served as clinical academic director for the Wellcome Trust funded PRIDE research program, which was implemented in partnership with Sangath and Harvard Medical School. His work with PRIDE has led to the development of a suite of scalable psychosocial interventions for use in secondary schools in India and also more widely. Over the next 30 to 40 minutes, we will hear first from Daniel through a presentation about his experiences and work developing programs in LMIC settings. And then this will be followed by time for Q&A. And please feel free to use the Q&A box in the Zoom chat area as well if you have any questions throughout the presentation, and we'll take as many of those as we can at the end. So welcome, Daniel. We're really glad that you can join us today, and I'll hand over to you now. Sorry, Daniel, you're on mute.
There you go, off to a good start already. Thank you, Patty, for your very kind introduction and the invitation to speak with you today. And thanks everyone for joining us. I'm sure that a number of people on this webinar will be familiar with aspects of the PRIDE work. So what I've tried to do today with my presentation is to focus on what I think are some of the important lessons that certainly I'm taking away from the PRIDE work, because we're nearing the end of the PRIDE program. As Patty mentioned, it started in 2016. And by the time we complete the project officially, it'll be the end of September. It'll be almost 7 years since we started. So obviously there's a huge amount of work that has gone on in the 7 years. So, to distill that down to kind of 30, 40 minutes is not so straightforward. So necessarily I'll have to be selective in what I talk about. And a huge number of people have contributed to this work. The slide I'm showing now, this was a snapshot done, I think maybe in 2017. We've had lots of colleagues who've joined the program since then, others who moved on. And I just want to I can't name everyone, but I just want to pay tribute to the entire team of collaborators in India, especially, also around the world. Okay, so I am going to give a little bit of background to adolescent mental health from a global perspective. I'm sure many of these points will be familiar to the audience here, but I just want to kind of orient us in the kind of wider global perspective before talking specifically about what we've done in India. I'll give a bit of description of the PRIDE program, and sort of what we've tried to do over these almost 7 years. And then I've picked out 4 lessons that I think are worth paying particular attention to, and I'll back those up from some evidence from the Pride program. And it's very much edited highlights. And I'd encourage kind of anyone who wants to kind of delve deeper into these lessons or the points raised in this presentation to look at the papers, but also we have a sort of a dissemination event planned for September. I'm sure we can share the exact date of that for those who aren't aware of it, sort of in the chat, sort of at some point during the presentation, so that anyone who's interested in hearing from the wider group and delving even deeper into the findings, kind of they can join. I think that's open to the public, and anyone who's interested can join that event. And that's happening in September. Okay, so low and middle income countries comprise 90 years. So when we think about global youth mental health, or kind of youth mental health generally, overwhelmingly we're thinking of adolescents and other young people who are living in low and middle income countries. And this map shows the kind of distribution of ages, median age of populations across the world. The darker reds suggest older populations. The kind of pale colors suggest younger populations. And just at a glance, you can see that the oldest populations are in sort of Western Europe, North America, Australia. And if we look at the parts of the world where low and middle income countries are concentrated, we see younger populations. So to address mental health problems in early life on a global scale, we are very much thinking about low and middle income countries. This slide here is showing sort of rankings of mental disorders and how these rank based on where they were placed in the sort of very large global burden of disease study. And this is showing rankings of disability adjusted life years. So basically this is showing, gives some sense of the impact on sort of social occupational functioning, the disruption to kind of activities of everyday life caused by different health conditions. And the numbers in each square, so say in the top left, it says 13. That's where, in this case, depressive disorders rank alongside all other health conditions globally, okay? So we can see that in terms of the types of mental disorders that are most common, if we're interested in adolescents, it's very much conduct disorders, anxiety disorders, and depressive disorders that across these two age groups, the 0 to 14-year group and the 15 to 24-year-old group. It's these three categories that collectively contribute to the greatest amount of disability, right? So in Pride, it's this collection of disorders that we were interested in: anxiety, depression, and conduct problems. And of course, these problems often co-occur, all right? And not only are these important in terms of, you know, which mental health problems we're going to focus on, but relative to all other health conditions, these disorders rank very highly. So, for example, in 15 to 24-year-olds, depressive disorders are the fourth greatest cause of disability adjusted life years, and that's relative to all health conditions. Okay, so the terms on this slide will be familiar, I think, to most people in this call. There's the treatment gap. That's the difference between the number of people who need and actually receive mental health care. There's the quality gap. So that occurs when there may be care available, but it is not the optimal care. It is, you know, substandard in various ways. And there's also prevention gap, which perhaps doesn't get talked about as much as the treatment gap or quality gap. And that's poor coverage of interventions that target risk factors for mental health problems. So how can we address these various gaps? Well, task sharing is something that is now pretty much the sort of conventional wisdom that this is this approach is critical to meeting to sort of overcoming resource constraints. Sangath, of course, has been a global innovator, pioneer in task sharing for mental health problems. It's not without its challenges. These have been kind of written about, quite extensively now, and written up in systematic reviews. So it can be stressful for the providers who are doing this work potentially for the first time, particularly when there's a lack of adequate training and supervision. People in task sharing roles can encounter skepticism from healthcare professionals, and sustaining task sharing beyond an initial reasonably well-funded research project is also a major challenge. So how to embed sustained task sharing in routine kind of public health services. So these are all issues that we have grappled with to an extent in PRIDE, and we are kind of continuing to grapple with. Also just want to say something about the promise of technology. So there is great enthusiasm about the potential of technology to help to close the treatment gap. In particular, young people are known to be the earliest adopters of technology worldwide. So there has been rather a lot of enthusiasm about the potential of, for example, apps and online interventions to help with early detection, but also early intervention for mental health problems. Quite a lot of sort of studies looking at acceptability, feasibility now, but kind of well-designed, well-controlled studies looking at effectiveness are quite rare, especially in low resource settings. Another issue that is really important to think about when it comes to addressing some of these gaps in provision of services are about kind of cultural applicability of interventions that have commonly been evaluated in the first instance in sort of high resource settings, and even within kind of high income countries, they have historically been developed, particularly with white middle class populations. So there is evidence that culturally adapted interventions are more effective. So it's not just a kind of a philosophical point, should they be adapted or not, but adapted interventions have been shown to be more effective through systematic reviews. And there's also an ethical dimension and the potential for kind of adverse effects arising. So bearing this in mind, kind of cultural adaptation has been sort of used in varying ways in sort of global mental health intervention development projects. But broadly speaking, there is now some consensus towards an iterative, phased adaptation approach. And when I say adaptation, I mean, sometimes it involves taking something that is fairly well established from another context. In others, it may be a bit more of a bottom-up process, but nevertheless, these three phases would quite often be followed. So there's an initial phase, formative phase of assessing beneficiary needs, stakeholder priorities, and the available resources, then identifying relevant strategies that may help to address these needs and priorities, developing a theory of how an intervention might produce desired outcomes. And then one moves on to kind of an evaluative phase. And then one kind of can circle back based on findings from evaluation, changes would be made to the intervention, and one would go through another iterative phase of development and evaluation, kind of leading typically to randomized controlled trials. So this is basically the approach that we've followed in PRIDE. It also our approach builds directly on earlier work that was done through Sangath in the Premium project. The Premium project was also led by Vikram Patel and funded by the Wellcome Trust, and was, to say, the precursor to Pride. And Pride stands for Premium for Adolescents, so that it is explicitly acknowledging the debt to Premium. In Premium, the focus was on adults with depression, adults with alcohol abuse, and 2 different interventions were developed and tested in randomized controlled trials. In Pride, we were working on common mental health problems. And I mentioned earlier how conduct problems, anxiety, and depression make up the bulk of mental health problems that have some significant bearing on social disability. That has been our focus in Pride, and we've taken a transdiagnostic approach. And we've been working in Delhi and Goa, and I'll say a bit more about how the specific activities were sort of dispersed between those 2 sites. But yeah, so our focus was on transdiagnostic interventions that would be effective across an array of common adolescent mental health problems. We focused on schools and delivering interventions in schools. So you can imagine why schools would be a very relevant focus for adolescents, and as a way of reaching large numbers and incorporating interventions into kind of routine service provision. We're also interested in the potential of digital strategies to support scaling up. The work has run over 7 years. We've published a number of formative and pilot studies. And we've also undertaken 4 randomized controlled trials, and we've had 2 PhD students embedded in the project as well. Okay, so this slide is just saying a bit more about the sort of building blocks, the theoretical foundations of the Pride intervention approach. And I'd encourage anyone who's interested in going a bit deeper to look at the published papers, and I have a bibliography in these slides, so anyone who's interested can get hold of the slides and work through that bibliography. So we were interested in, as I said earlier, taking a transdiagnostic approach to understanding, targeting risk and protective factors. We were interested in sort of thinking about how the wider social ecology in which adolescents are living and growing up, how there's an interaction between that social environment and individuals' kind of coping resources. And so the idea was that by building coping skills, adolescents would have would be better equipped to cope with stresses of daily life, and where it was not possible to operate directly on an environmental stressor, they would have sort of emotion-focused coping skills that could be used to address kind of the negative emotional reaction. So anxiety, depression, anger that may persist in some cases. We have used a stepped care model. This involves kind of sequential treatments where the first step is brief and relatively low intensity, to use the jargon. So it requires fewer resources, less time to implement than sort of the second step, which is made available to those participants who don't respond to the first step. And the second step is a bit more differentiated, a bit more specialized, and involves modules that can be selected according to the particular needs of the particular presentations of the adolescent. Whereas the first step, everyone gets the same module, which is problem solving. And in terms of why we've chosen these approaches, well, there is a strong evidence base now on stress coping and related CBT approaches. And in our formative work, with adolescents and other stakeholders, there seemed to be a good fit between particularly the focus of problem solving on dealing with kind of social stressors, and the ways in which adolescents kind of talked about their problems and the reasons why they may come for help in the first place. They're not coming for help necessarily saying I'm feeling anxious or depressed, but coming with an identified kind of social problem, be it in their family or their peer network. So problem solving fits well with that kind of way of kind of construing problems. And step care models have been used quite widely in a number of settings now, particularly in primary care, to help to kind of conserve resources. Okay, so moving on, this pyramid is showing how we've kind of the architecture that we developed around step care. At the base of the pyramid here, we've got what we call kind of step 0 as a shorthand. Step 0 is something that was offered kind of on a universal basis to classrooms, and that was about sensitizing adolescents and generating awareness of the services that we're providing, and basically generating referrals. This one step up from that is what we've called step 1. That's the kind of that's the problem-solving intervention that we have offered to adolescents who have kind of nominated themselves or been referred by teachers. So this is not a universal intervention, but this is something which is offered to those adolescents with a felt need for help. And we've developed 2 versions of this, sort of an in-person counselor-led intervention, and then a digital version developed for use on an app. And then the second step is tailored modular CBT, which we've offered to adolescents who fail to respond to step 1. And as you move up the pyramid, one has an increase in kind of resources in terms of delivery time and the training and supervision required. Okay, so moving on to think about the lessons, that some of the important lessons I think that we've learned. And the first one I've called here is that I've named here is show, don't just tell, as a way of promoting help seeking. And this relates particularly to the sensitization work that we've done. So, the background here is that there are relatively low levels of mental health literacy in the schools we've been working with in low-income communities in Delhi and Goa, and also stigma. And I realize that stigma is not confined to India. This is an issue kind of the world over. And previous research has shown that demand-side interventions, so these are interventions not about increasing the supply of interventions necessarily, but about increasing the demand for them. They're more likely to work when targeted directly at young people rather than going through parents or adult gatekeepers such as teachers. And there's been very little by way of kind of high quality evaluation done in low-income countries. So what we did in Pride is we built in a randomized controlled trial to look at the relative impacts of classroom-based sensitization, which involved classroom visits, a Q&A with a school counselor, and a video presentation. We compared that approach with an approach that was done on kind of a whole school basis that consisted of sort of consulting with teachers to sort of try and increase teachers' awareness and to generate referrals that way, and also putting up posters. Okay. This slide here is just showing kind of the steps that were used for teachers to refer. So this is part of the sort of one of the materials that teachers would have received as part of not so much formal training, but more sort of a briefing that they received about how they could refer students in. And in terms of how students could refer themselves, we had posters up in schools, and this is an example, but we also had these individual classroom sessions where the counsellor who was allocated to that particular school went and did a session to the whole class and explained the whole process of referrals and showed a short video that explained what happened in what would happen in counselling and the types of problems that counselling might be able to help with. And in terms of the relative impacts then of the kind of whole school approach and then the classroom intervention approach, we found that in the classrooms where the counsellor visited and, I said, did a bit of a show and tell, over 20% of students in those classes were referred, and overwhelmingly they referred themselves. In those classes where the information wasn't given in that way, where the information was given, say, through posters or just given in briefings to teachers, kind of just 1.5% of students in those classes were referred. So the classroom sessions made a massive difference to the number of referrals. However, that's not to say that those students who were referred were more likely to be suitable for the program. So overall, about a third of the referrals met our sort of mental health severity criteria that we had in place in this particular study. And that didn't differ between the conditions. So basically, students were no more or less likely to have elevated mental health symptoms if they were referred in either condition, but they were much more likely to be referred in the first place. Okay, so there's something about those barriers to seeking help in the first place that seem to be fairly well addressed through this kind of classroom approach. And I would venture that an important part of it, and this is something that came out in a little bit in some of the qualitative work that we did, an important part of it is that it was the counsellor themselves who did the presentation. It was putting a human face on things, and the counsellor was giving particular assurances about confidentiality, and they were generally coming across as a warm, kind person who was genuinely interested in helping, and that made an important difference to the adolescents and in their decision making about whether or not they were going to refer themselves. Okay, so another couple of lessons to mention, and I've sort of grouped these together because they relate to the kind of architecture of the step care model. So one important point is that even a very brief problem-solving intervention delivered by lay counsellors can have really quite sustained long-term benefits, but there seems to be some kind of diminishing effect of a second step in step care. So we did a randomized controlled trial where we compared a counsellor-led version of problem-solving, and so counsellors met about 5 times with adolescents over the space of 3 weeks, and they delivered a problem-solving intervention that was sort of supported by some handouts that explain problem-solving in a comic book format, and I'll go on to show those materials briefly after this. And that was compared with just getting the problem-solving materials by themselves. We also did a pilot study where those adolescents who didn't respond to this first step of problem solving, they were offered the step 2 intervention. So the handouts that we used in the trial were called kind of POD booklets. POD stands for problem, option, do it. Those are the 3 steps that adolescents were taught as a way of implementing problem solving. So basically, there were 3 comic books, each one roughly corresponding to one of the 3 steps of problem solving. They explained kind of or illustrated common like commonly stressful situations that adolescents might face, and they show the protagonist kind of using problem solving, the problem solving steps. And there's also part of the booklets that allow adolescents to kind of think about their own problems and work through the steps themselves. So in one arm of the trial, they had the booklets, plus they had a counselor to help them going through it. And in the other arm of the trial, they only got the booklets. And this slide is showing the effects over time on our two primary outcomes. The sort of graphic, the picture on the left is showing change over time on the YTP. That's youth top problems. That's an idiographic measure where adolescents define kind of what they think their three main problems are, and then they rate them from 1 to 10 at the beginning in terms of how much of a problem they are, and then they re-rate them again. And the box on the right is showing change in the strengths and difficulties questionnaire. That is a standardized measure of kind of mental health symptoms. So you can see in both on both outcomes there was a kind of problems and symptoms dropped over time. On the youth top problems measure, the change was significant at all three time points. That was 6 weeks, 12 weeks, and 1 year later. On the strengths and difficulties questionnaire, the difference between the two conditions at 6 weeks and 12 weeks wasn't statistically significant, but it was significant at 1 year. So worth keeping in mind that these sustained effects over a year was based on just a 5-session intervention delivered over 3 weeks, where these sessions themselves lasted just 20 to 30 minutes. So in total, they had, say, kind of a maximum of about 2.5 hours of contact time with a counsellor in total over 3 weeks. Yet still there was sustained benefits on, say, kind of person-centered problems, prioritized problems identified by the young person at the start, and also on symptoms more generally. This slide is just sort of summarizing some of the important kind of process indicators. So about 80% of the participants attended at least 4 of the 5 sessions, and the most common reason why participants stepped early was because their problems just got better very quickly. That accounted for about half of dropouts. As I was saying, sessions were most attended 5 sessions, and this was delivered over about 3 weeks. And the sessions themselves lasted usually between 20 and 30 minutes, with a mean of 23 minutes. Although there was some indications of higher kind of user satisfaction in the counselor-led condition, respondents in both arms were equally likely to say that they would definitely come back to the service and definitely recommend the service to a friend. So it's not to say that those in the sort of booklet-only condition weren't satisfied with what they received. And qualitative interviews that we've done and we've analyzed and we're now writing up for publications suggested that even very interactions they were valued by participants in the booklet only condition. So what I think this is showing us is that even very kind of brief interactions with a kind, warm, empathic adult in the context of what's mostly a self-guided intervention can help to kind of boost effectiveness. Okay, so just to say something about step 2 then, and kind of what sense we make of step 2. So we've published a mixed method pilot evaluation of step 2 that was sort of made available to those participants who didn't respond. Out of an original cohort of 80 adolescents who got step 1, those who didn't respond to step 1 were offered the chance of kind of further treatment through step 2. And we found that about half of those participants for whom we had available outcome data, they had not remitted. So they were still showing elevated symptoms or kind of elevated impairment related to those symptoms. And so they were offered the chance of further treatment. But interestingly, only 1/3 of those cases who, on the face of it, required further treatment actually opted in to something more. And the most common reason why they opted out was that they felt that their main problem had actually improved. So I think what we're taking away from this is that if one bases decisions about offering further treatment purely on kind of symptom scores, there may be, one may potentially overestimate the need for further treatment, and there needs to be kind of a more nuanced, more sort of person-centered approach to identifying whether or not further intervention is going to be helpful or not. And so the youth top problems measure that I mentioned before, we've now moved to a place where that is the measure that we are using to make decisions about whether or not further intervention might be helpful. And we've also moved to a more kind of collaborative decision-making approach. And there are also some important things to come out of this study about trying to make treatment as efficient as possible, reducing the gaps between step 1 and step 2. And adolescents were also keen that the same person should offer both step 1 and step 2. The idea that a more experienced, more specialized person would come in for step 2, that isn't something that adolescents were very keen on. Okay, now, if we'd had time, I was going to show a video that has some testimonials from participants, from young people who've actually received the step 1 intervention. What I'd encourage people to do is, and it's just a short video, about kind of 3-4 minutes, is to, in your own time, kind of paste this YouTube link in your browser and have a look at it, because I think that this offers a really helpful kind of counterpoint to the hard numbers that we've generated in the trial. And I think it helps to really kind of bring alive some of the some of the issues about kind of some questions that people have raised about how meaningful are these changes that have been achieved in relation to sort of the intervention and its effectiveness. What does an effective intervention look like in practice for those who take part? And lessons that apply to the work that we've done around the digital side of things. We've developed a digital version of the problem-solving intervention called the Pod Adventures app, and it involves a game where adolescents get to explore kind of a virtual world, and it's an opportunity to learn the problem-solving steps. And then there's part of the app where they can then sort of apply their steps to their own problems, and they can practice certain coping skills through mini games. And this was developed initially so that although it would be delivered on kind of a smartphone or a tablet, physically adolescents would be getting hold of it in schools. So they'd be using it on digital devices in schools, not at home, right? And we've also more recently had some experience of trying it out in a different way, where adolescents have been using it at home online, and that was necessitated by the school closures during the pandemic. So this is a screenshot kind of showing the Pod Adventures app. I won't say a huge amount about what the app does or what it looks like. I've got a few more slides here that have a few screenshots. If anyone's interested, I think that there's more information about it, potentially on the Sangath website, or certainly in the publications that we've that relate to this part of the program. Here's a few more screenshots. Yeah, and these photos at the bottom are showing the school-based format, where adolescents would sit with headphones in a kind of shared classroom. At the front of the class, you see the counselor who kind of gives them a bit of orientation to how to use the app, and is available if they want to do any kind of, if they get stuck with anything. So this just helps to make the whole process a bit more efficient, and they're not relying on accessing kind of a device outside of school, which may be difficult for them for a number of reasons. So when we evaluated this kind of school-based approach here, we found that although it was an uncontrolled evaluation, there were some really promising signs in terms of the impact on problem severity and mental health symptoms. There were high levels of engagement. Adolescents really liked the app, and we found that it was really efficient in that it only took about 10 minutes of counselor time per student to kind of orient them and support them through the use of the app. As I mentioned, we have made some changes during the pandemic, and we ended up shifting a randomized controlled trial that was originally going to happen in schools, shifting it to online delivery. And it was really quite an eye-opener in terms of seeing the challenges that came up in terms of adolescents accessing it outside of school. So although there were over 1,500 students sensitized, and this is through a combination of kind of online webinars, and I think in some cases adolescents were able to go to school to get the sensitization, even though they were learning at home for much of the time. So there are 1,500 students sensitized, but only 11 actually enrolled in the study, and an even smaller number actually did what they were required to do to actually use the app in a meaningful way. So just to kind of wrap things up a bit then in terms of our takeaways from these activities on the whole. So we found that brief counselor delivered problem solving is effective both in the short and long term. Problem solving seems to be contextually and developmentally appropriate for population of disadvantaged, stressed adolescents who really want their problems to get better quickly, and who frame their problems in terms of kind of psychosocial difficulties rather than overt symptoms. And I would say, based on work that I've been involved in some other kind of low resource settings, this seems to come up a lot. And in fact, it's true sort of adolescents in the UK and kind of the world over, that for many of them, they want a fairly quick, practical solution. And if they're going to stick with something over a period of time, it needs to be credible and relatively easy to use and fit into their busy lives. So we don't want to make interventions longer or more complicated than they really need to be. So one reason for making interventions brief and simple is okay, well, they're cheaper to deliver, but actually I think there's strong indications that they're also just more acceptable as well when they're brief, and when they're kind of easy to use and fit well with the local context. Another important thing is about kind of the non-specific aspects of counseling. So having a counselor who's good at listening, who's warm, who's empathic. These were really very positively received. I mean, this is something one sees time and again in psychotherapy research, but I think it's reminded to us not to overlook those elements when we're thinking about technical solutions, such as, algorithms for selecting and combining practice elements, and this idea that sort of, if we can just automate interventions, there'll be, where we don't have skilled people to deliver them, this automation will somehow overcome lots of problems. But the human element is really critically important still. In terms of problem solving, how it might fit into step care, it did seem to fit kind of logically as a kind of foundational skill that they could then lead on to further coping skills. However, there is this potential mismatch between stepping adolescents up based on symptoms versus whether or not they more subjectively felt there was a need for an intervention. So that's something that's really important, and I think coming out of Pride, that's certainly an area for further work, looking at what shared decision making might look like, particularly in the context of task sharing, and what kind of training less experienced people might need in order to make some of those more nuanced decisions about the need for further treatment. And just kind of some final points here about the digital side of things. I mean, one doesn't want to, despite the enthusiasm for technology, one doesn't want to kind of understate the barriers that still exist and that can restrict scalability. We really need kind of time efficient, resource light formats that can help the hurdles to getting online, but also staying online. So one way of doing that might be kind of single session interventions rather than multiple sessions. And I think there could also be some value in hybrid approaches. So where an adolescent might initially get access to a device in school and might have it explained to them in person, and then might potentially do some work on it at home or in another setting, but at least to have some in-person opportunity to access the technology and interact with some kind of guide. So this slide is just really pointing out some further directions. We are just finishing up now a randomized controlled trial looking at different approaches to training counselors to deliver the step 1 intervention. Because of the pandemic, our plans to evaluate pod adventures and step 2 in randomized controlled trials, we didn't get as far as we wanted. So that's certainly something that we'd like to try and do in the future with additional funding. And there's also quite a lot of interest at the moment in extending particularly step 1 to other LMIC settings and possibly also even in high income countries. And there's been some bids that have gone in recently to adapt Pride for HIV affected youth in Kenya and Uganda. So if anyone is interested in delving deeper, this paper here is a good starting point. This sort of brings together sort of outlines the developmental work that went on in the first kind of 2 or 3 years of the program. And then we have a full bibliography on these slides here. So I shall end there, and hopefully we have enough time for some questions.
Thank you so much, Daniel, for that very comprehensive presentation. We do have time for questions. We've got a few, and if it's all right, I'll just read them out one at a time for you to answer.
Sure.
A couple of these might have been covered, but it might be good maybe to cover them a little bit more. We've got one question here that says, could you explain what happened to the other intervention arm of the RCT? So the control arm.
What happened to them in terms of the outcomes? Yeah, what happened to them? Well, we've got, this slide here is showing, so the control arm is the blue line, and the counselor-led intervention arm is the red line. So there was a drop from before the trial to kind of immediately afterwards, and then sort of again at 12 weeks and a year. There's a drop in both kind of idiographic problems and in symptoms. It's just that drop wasn't as large as the drop in the counselor-led intervention. So there was improvement over time, but just not as substantial an improvement. And in the qualitative work we've done, it does suggest that improvement is not just, I think, regression to the mean for some participants. That there are, they were able to glean problem-solving skills from the pod booklets, and that was helpful for them. They may not have continued to use the pod booklets beyond the first few weeks, but the problem-solving skills are something that they may have continued to use spontaneously, or the fact that they were able to get some early problem resolution by using the problem-solving skills, that's been beneficial to them in the longer term, and they maybe felt more confident at dealing with new problems as they've arisen.
Thank you. The next question has 3 sort of sub-questions. So the first one is, were there any barriers or cultural barriers specific to India? The second is, was there a referral system set up for the tailored CBT? And the third is, what was the strategy to prevent contamination? So any order that you'd like to answer those in.
Yeah, so was a referral system for step 2? Yeah, is that it? But for the second question, sorry, no, so there wasn't a referral system. I mean, everyone who was referred in, and most of the referrals came from adolescents themselves. They started with step 1, and the decision about whether or not step 2 would be initiated, at least in an early iteration of the program, that was based on their symptom scores and the kind of functional impairment that was apparent at the end of step 1. So if they were still above certain thresholds for symptoms and impairment, they were offered the possibility that they were offered further treatment through step 2, and they could decline that, or they could accept it. And about a third of them accepted the treatment. We subsequently changed things so that the decision about whether or not they wanted some further treatment, that was a bit more subjective and wasn't based on any sort of like set threshold, but rather whether or not the adolescent felt that there were still problems that would benefit from treatment. So it wasn't, you couldn't be referred directly into step 2. You needed to work through the steps. And the third one there was about contamination, right? So in the trial, I mean, the potential contamination could come through sharing of the pod booklets, but participants in both arms got the pod booklets, so that wouldn't have been possible. And other potential sources of contamination, well, we only had counselors in one of the arms, so sometimes you can have contamination because you have different intervention providers in different arms, and they share experience, or the same intervention provider provides 2 different interventions, and that didn't happen either. So I think the design was quite effective at mitigating against potential contamination. And the first question, which I've left to last because I think it's maybe a bit more complicated, that's about cultural issues and how they may have affected what we did. One could give quite a long answer to this, but one thing that comes to mind immediately is the emphasis that is commonly placed on kind of cognitive behavioral therapies in sort of the high-income countries and Western contexts where they're originally developed. There's a lot of emphasis on kind of guided discovery and a certain type of kind of collaborative relationship that is founded on kind of guided discovery, and one as a therapist is not expected to be a sort of how can I put it, is meant to sort of like not be too directive in the therapeutic stance that they take. Now what we found is that kind of approach didn't seem to fit so well with the expectations of the adolescents, and given the sort of academic context in which they are, where there's lots of rote learning and quite a didactic approach to learning new things, there seemed to be an expectation on the part of some adolescents that the counsellor would tell them what to do and would tell them what solutions to choose for their problems, and that's not the way that problem solving was originally kind of construed in the context of CBT. So we, I think we had to work within that, there's slightly different expectations, and arrive at a sort of an approach that so isn't just putting it all on a plate, but does allow counsellors to be perhaps a bit more directive and a bit more willing to sort of make some, gently suggest some potential solutions, particularly for those adolescents who seem to be a bit stuck or finding it hard to generate solutions spontaneously. yeah, so that's one thing that comes to mind.
Thank you. I think this is our last question. It's a bit of a big one, but how do you sustain this kind of whole school approach in the long term? How to engage with the healthcare sector, primary and secondary, and with schools?
Yeah, I mean, that's the billion-dollar question, isn't it? And Pride wasn't specifically set up as a sort of a program of implementation research, in that, yes, we were looking to develop something and apply it in real world settings, but looking systematically at all the factors that might affect implementation. Not something that we have specifically done, although we certainly have indications about things that may be may be useful to implementation. Perhaps I can speak to the particular challenge of kind of sustaining workforce competencies, and we have developed a digital version of the training for counselors who deliver step 1. So this exists entirely sort of online. It has training videos, it has readings that can be accessed through the digital platform. It has kind of quizzes that people can use to test their knowledge, and it sort of involves about 20 hours or so of self-study over a period of about kind of four weeks. And we are currently evaluating the effect of this training on the competencies of kind of novice counselors, and comparing whether or not there's a difference between a pure self-guided digital package and then a digital package that's supported by a coach. And so I think that that gives us an opportunity to implement the intervention in a number of different contexts without needing to devote a lot of resource to kind of repeating in-person training and having like a train the trainer model, or having to find relatively experienced people to deliver the training. I mean, we have now this standardized training package. Of course, supervision is still needed after that, but I think that standardizing the training can overcome a really important hurdle to at least developing the workforce. And I think some next steps will be not just seeing, does the training in theory make people more competent, but how well does the training actually translate into improved outcomes for adolescents who receive the intervention, and also looking at different kind of supervision models and how they can be sustained over time as well.
Great, thank you. I think you've covered all of our questions, and we are also out of time, but thank you again. And on behalf of Sangath, thank you to everyone who attended, and especially Daniel, thank you for your time and for the excellent presentation. For anyone who is interested, I mean, we can make all of the references available and share those with you. We had a lot of questions about data and papers in the chat, so we have tried to answer as many of those. But if anyone would like more information, please do email us, and we're happy to share the papers with you. And for anyone who is also interested to join the wider Pride meeting that Daniel mentioned earlier on, we've put the registration link into the chat, and you'll also hear from us about the next webinar for August. Thank you again to everyone who attended. Have a lovely evening ahead. Thanks again, Daniel.
Great, thanks everyone. Thanks for the really good questions, and yeah, by all means, drop me a line if there's any specific questions. Thanks to Patty for offering to sort of make the references of bibliography available, and yeah, thanks everyone for your interest.
Thank you.